I'm hoping today really is to discuss some of the effective interventions that we know that work with frailty, but also a little bit around prevention of frailty and how we can consider that frailty isn't an inevitable consequence of ageing and the things that we can do effectively in earlier life. So, as Bev said, I'm Helen. I'm a nurse consultant for older people, and I work clinically in Cornwall. So right at the end of the county, where I'm clinical lead for the community matron service here, and also provide some rapid access clinics and full assessment clinics for older people. And I've been on secondment now to NHS England for just about a year, and I've got another year to go as clinical lead for frailty, developing some work that we've done, developing frailty guidance, etc. So just going to see if I can work the slides. Yep, that's fine. Bev's already shown you the learning outcomes for today, but what I'm hoping to do really is to talk about some of the preventable components of frailty, think about how we as clinicians and other people who work with frail older people to prevent and delay the adverse effects of frailty, and also just to understand what interventions are effective across the trajectory of frailty. Because what we do know is one size doesn't fit all, and we know that people progress through frailty from mild to moderate to more severe, and there are different interventions that are effective at each part of that trajectory. So let's start off just by thinking about where is frailty, and the quote you can see there on your screen is from a geriatrician colleague of mine who said to me, well, I know it when I see it, but it might not be the same as what everyone else sees. And I think for me this really sums up the whole paradox of frailty. We know it's out there and it's actually quite common. So you've got some prevalence figures there on your screen now. So people who live in the community aged 65 and over, between about 7 to 12% of those people will be frail. We know that frailty increases exponentially with age, so if you're 85 years and over, between 1.25% of people can be classified as frail. So it's very common, it's out there, but currently frailty isn't often recognised, it isn't diagnosed effectively as it should be, and it's not recorded. So often we don't know where the frail people are and what we can do to support them to live their lives well with frailty. So let's just explore the whole syndrome of frailty first of all, just to set us off on thinking about what we can do to prevent it and to manage it when it is there. So we know that frailty is a clinical syndrome. It's a syndrome of increased vulnerability, of becoming much more vulnerable to stressors. And just to think how this actually happens, and maybe to put a bit of a proposition to you about how this is how frailty develops. So we've got life course determinants that are there for all of us. There's not much that we can do about those. So they're often biological, genetic, psychosocial, environmental, all of these factors that affect us in our everyday lives. They are often determinants of frailty as we move on and age. And then as we age, we start to get that decline in our physiological reserves. So if something happens, like a minor illness or some other stressor, we haven't got the reserves to fight back against that stressor that we perhaps would have had when we were younger and before we started to become frail. And of course, about this time as well, we start to accumulate multiple long-term conditions. We know that most people aged 65 and over have 2 or more long-term conditions, and people over 75 years have 3 or more. So we start to accumulate long-term conditions at about the same time as we start to have this decline in our physiological reserves. Now, about this point, frailty starts to occur, and you can see on the slide there I've talked about a period of reversibility, and there certainly is there, and it's the triangle there is shaped that way because in early frailty we really have some very good opportunities to think about how we reverse the effects of frailty and how we support people to do that. So I'll talk a little bit more about that as the presentation goes on. So when we're thinking about how we can reverse or prevent deterioration in frailty, these candidate markers are the things that we should be thinking around. So nutrition, mobility, activity, strength, endurance, cognition and mood, all the things that are important and we know are contributing factors to developing frailty. And we also know that if we don't intervene at that point and we don't support people to prevent deterioration in frailty, then we will start to see some adverse outcomes. And for frailty, those are becoming more disabled, becoming less independent, morbidity, hospitalisation, institutionalisation, so perhaps needing to live in a care home, and death. So we know those things will happen. But I guess what my thoughts are here is that at each stage of this trajectory, we can think about how we can prevent and support people. So even in early frailty, we can think about how we can prevent and delay adverse outcomes. We can think about primary prevention and health promotion. So there's lots that can be done at all stages of the trajectory, and I think sometimes that's not understood. It's felt that frailty is an inevitable consequence and there's nothing we can do. And I think the evidence is there strongly now that that isn't the case. So I just wanted to highlight this for you, which is a nice public health guideline, which is out for consultation at the moment. Should be finally published in the summer of this year, I understand. And it's called Dementia, Disability and Frailty in Later Life, Midlife Approaches to Prevention. So what this guidance does is it talks about how we can think about preventing frailty in later life by taking certain actions in midlife and addressing common risk factors. And if you look at the risk factors there, you know, they're nothing that we don't already know about, and things that we should all be thinking about addressing, particularly in midlife. So quitting smoking, increasing physical activity, reducing alcohol consumption, maintaining a healthy diet, and maintaining a healthy weight. All of those things we know contribute towards the prevention of frailty in later life. And just a little bit more information there from the guideline. You know, we know that there is a start of decline that can happen in midlife and even earlier. So, for example, there's a few depressing facts which says that the start of a decline in cognitive functions can happen by the age of 45. And there's actually an age-related decline in walking speed after the age of 30. So these things can start to happen. The clues can start early in life. But we also know that midlife is a really important time for making meaningful changes. You know, people often need more than one attempt to change, and midlife can be the period where that change is finally sustained. So what I think is important there is the last message, is that we're perhaps not getting those messages over to the general public. You know, I think we all understand now the risks between smoking and cancer, for example, but do we all understand the risks of these other factors and the likelihood of us developing frailty, dementia, and becoming more disabled in later life? I'm not necessarily sure we've got the public health message out there, but perhaps that's something we could debate in when we've got some time later on at the end of the presentation. Now, this graph that you're seeing there on the screen now is from some research that was done a few years ago now, looking at categorising people in a general practice population into fit, mildly frail, moderately frail and severely frail. And what this tool, which is called the Electronic Frailty Index, does, it helps GPs to categorise their population into those categories and to then think about having a frailty register so that we know which patients are mildly frail or moderately frail, for example. But what we've been able to do since this time is to think about what interventions are effective at each stage of that frailty trajectory. So people with mild frailty should have the opportunity to be supported in their self-management. And I'll tell you a little bit about some work that we're doing in NHS England to support that self-management. We know that as people become moderately frail, they respond well to care and support planning, so having someone to work with them in developing a care plan to help them to achieve their goals. And we know that as people become more severely frail, they really need active case management, and we also should be considering end-of-life care at this point, because if you look at the graph there and you look at the number of patients that are severely frail that are actually alive in 5 years, those numbers are very small. So those patients, we should be thinking about advanced care planning and their wishes for their end of life. So let's just think a little bit more around proactive interventions in frailty and when we should intervene. This graph many of you might have seen before. It came from the Lancet a couple of years ago, a very interesting study. And if you think about the frail person going along on that red line, so they seem to be quite independent, they're probably managing relatively well at home, and then the stressor that I've already mentioned happens, like a minor illness, or maybe a well-meaning clinician gives them another tablet that causes side effects, or maybe something happens in their social life or their environment that causes them stress. Often that person will then, because they don't have the physiological reserves, they'll often dip down below the line and become dependent and need help. And interventions then are required to support them to get back to their level of independence, and often they don't get back there without effective interventions. But what I'd like you to think about is, could we have intervened earlier, before that stressor happened that caused that person to lose their independence? So let's think about maybe 10 years ago. Well, maybe at that time, that person was saying, I'm not as steady on my feet as I was, I'm just not getting around as well as I did. Did we listen to that? Did we support them? Did we put in place any effective interventions to support them to self-manage more effectively? And maybe 2 years before the crisis happened, perhaps that person's daughter was saying, my dad is slowing down, he takes him so much longer to get dressed in the morning, he used to be able to walk to the post office in 10 minutes, now it takes him half an hour. Again, the clues are there, all of these are indicators of frailty developing. And then maybe just a month before the crisis happened, perhaps the carers who were seeing that person were saying, he's a fall waiting to happen. How many times have we heard that description? But again, did we intervene at that point? And there are certainly elements all across that journey where we could intervene effectively. The first thing I'd like to sort of draw your attention to really is the importance of supportive self-management for frailty. And when I talk about self-management, I don't just mean providing information, leaflets or booklets or telling people to go and look things up on the internet. For me, self-management is very much about the definition you've got on the right-hand side there, which is about the person being in the centre of their own care, of empowering them and their families and carers to handle their own conditions effectively as possible. And we as clinicians need to support them to do that. So what can we do in terms of frailty? Well, we know, and the evidence is very clear, that there are modifiable risk factors that I've already mentioned, which are associated with functional decline in older people who live at home in the community. And I've just got a list there of some of those. We've already talked about some of them, but as people start to get frail, we need to be thinking about things like falls, physical inactivity, polypharmacy, vision problems, and social isolation and loneliness. So this is very much a more than medicine approach. As clinicians, we don't have the answer to this. This is very much about engaging with community and with voluntary sector groups, etc., to support people as they become more frail and to address some of these modifiable factors that we can help people to improve. I wanted to show you this document. Some of you may have seen it. This is a practical guide to healthy ageing, which NHS England have developed in conjunction with Age UK. It's published on the Age UK website, and it's also on the NHS Choices website, so you can have a look at it, and you can order hard copies from the Department of Health order line. And what we've tried to do in this really is just put together it's only very short, it's about 7 or 8 pages, for people if they're starting to slow down, if they're starting to feel less steady on their feet, if they're starting to feel that they're less independent than they were at home, they can have a look at this guide, and there are some very practical tips on what they can do themselves. And you've got a list of just some of them there, so things about how to keep active, how to prevent falls, making sure you're having appropriate vaccinations, and things about mental well-being. So it's there just to try to give people that information where if frailty is starting to develop, they can support themselves with our help. I just want to show you one of the pages from that document, and this is what we call the gait speed test. So this is a recognised valid tool for diagnosing frailty. What we've done is translated that into language that older people can understand and can identify with, and it helps them to think about if they have started to slow down, are they starting to become frail? Very simple test they can do at home. It's basically if it takes you longer than 5 seconds to walk 4 metres, you're frail. You are starting to develop the signs of frailty. And then from that, we then signposted them to parts of the guide which can help them to manage more effectively, but also signposted them to areas of support and places where they can go to get help at home to regain and retain their independence. So I guess just to start to sum up really, in terms of supporting self-management, we know that the key messages are thinking about the language. No older person is going to say, I'm becoming frail, and in fact some recent Age UK research said that older people don't identify with the term frail themselves. But what they might start to do is, say, things are taking me longer, I've got less energy, I don't feel as confident as I did at home. And I guess the key thing for us is to think about focusing on health and well-being in later life, because these and promoting independence are concepts that older people really identify with. And I just wanted to just highlight the issue of social isolation and loneliness. We've got a few facts and figures there, but the research shows us very clearly now that social isolation and loneliness are independent risk factors for developing frailty. I mean, the final point there, lacking social connections, is actually a comparable risk factor for early death from frailty to smoking 15 cigarettes a day, and is actually worse for older people than for their health than obesity and physical inactivity. But again, we haven't necessarily got the message out there, and it's how we think then about re-engaging people back with their communities and enabling a network of support to prevent social isolation for older people.